Hi everyone, thanks for registering and coming to our lectures. My name's Rod Pattinson and I'm going to talk about slipped upper femoral epiphysis today. I'd like to look at it as a case study. A 15-year-old boy presents with left knee pain and a limp a week after coming off his bike. For 2 months he's had a sore left knee on and off after football, and his mum has noticed him limping from time to time. He's had some chiropractic treatment for his knee, and an X-ray of his knee showed some changes of Osgood-Schlatter's disease. The boy walks with an antalgic gait and a limp, and he walks with his left foot a little externally rotated. He has a positive Trendelenburg sign, so when we ask him to stand on his left leg, the pelvis drops on the right, indicating there's a mechanical problem with the left hip. He lies supine with his left leg in slight external rotation, and there's no swelling or tenderness around the left knee. There's 1 centimetre of shortening of the left leg. There's a normal range of motion of the left knee and no tenderness, and on flexing his left hip, the leg goes into abduction and external rotation. Attempts at internal rotation at that position cause knee pain. X-rays of the left knee show irregularity of the tibial tubercle apophysis, and X-rays of the left hip show a grade 1 slip, less than 30% displacement of the upper femoral epiphysis. This is the AP Pelvis X-ray, and you'll note that the growth plate on the left here, at the red arrow, looks wider and irregular compared to the other side. This is what's called a frog leg lateral view of the hip, and this is the important X-ray. Note that the epiphysis, where the asterisk is, looks like a scoop of ice cream falling backwards off a cone. It's that posterior displacement that causes the external rotation and abduction deformity. The boy is placed on crutches touch weight bearing and referred to a surgeon for pinning of the hip in situ as a semi-urgent referral. That operation involves passing a cannulated screw across the centre of the growth plate under X-ray image intensification. It can be done as a day-stay operation. Here's a view of the pelvis showing a pinned left hip. Slipped epiphysis is a semi-urgent problem that can cause serious hip deformity predisposing to premature osteoarthritis. The diagnosis is commonly delayed. The presentation can be chronic, more than 6 weeks, acute, or acute on chronic. It's more common in overweight and active teenagers, but also occurs in normal weight, sporty kids. Pinning in situ prevents further displacement and encourages growth plate closure. Excessive deformity of the femur may require treatment by osteotomy after pinning. The pain felt in the knee is referred pain from the hip via the femoral nerve. Importantly, both hips may be affected in up to 30% of patients, and the patient and carers should be warned to return if symptoms develop on the other side. Key points to take home are that any adolescent with thigh or knee pain and/or a limp should be considered to have a slipped epiphysis until proven otherwise. The treatment of choice is pinning in situ as a semi-urgent procedure, and post-operatively the patients should use crutches part weight bearing until there's evidence of growth plate narrowing on X-ray. That usually takes at least 6 weeks. Thanks very much for listening and for coming to our lectures. Bye.